Welcome everyone, and everyone using Zoom. Welcome to this exciting course about population medicine and health policy, causal evaluation. I'm a group leader, research group leader for health economics and population economics. And it's really exciting to start this class. And in this class, we are first going to learn the basic concept of what is population medicine. And but the most important thing is to learn the causal evaluation methodology in this class. Today is an introduction lecture. I cannot use my keyboard. Okay. So today's introduction lecture. I will just first briefly introduce you with the definition and concept of population medicine and compare it with other disciplines. And then I will briefly introduce you about the causal evaluation, what makes a relationship causal rather than association. And population medicine is an important domain, and it is evolving as a hot topic currently, and it has been established in the United States at Harvard Medical School, and now China has launched a new discipline called population medicine, and Peking Union Medical College is taking lead to design the curriculum because it's relatively new comparing to the other disciplines. There are two key ideas behind this concept of population medicine. The first idea is population medicine is the science of combining public health and clinical medicine. What does it mean? We know that public health focuses more on prevention and clinical medicine focuses more on treatment. And population medicine is actually combining prevention and treatment together because actually prevention and treatment cannot be separated. We cannot say health is a discrete state. Somebody is really healthy, is fully healthy, and then he suddenly became ill. It's actually a continuous status. You are in a fully healthy status, and then you are less healthy, and you're healthy, and there's some syndrome that's starting to show. And once you cannot bear your syndrome, you go to the hospital, and the hospital say, okay, you're having this disease, and start treatment. But actually, health is a continuous state, evolving. And another perspective is that treatment is kind of a prevention because once you start your treatment, you're actually preventing the disease from progressing. You are actually from this person from death. And you can view that or think about that, think about treatment as a sort of prevention. And you can also think about prevention as a kind of treatment because sometimes you are not in a fully healthy state. You may start to take some, to exercise or to use some relatively light treatment as a prevention. So in light of this, the key idea behind population medicine is that it combines, it merges the prevention and treatment together and view health as a continuous state evolving across the life cycle. And another key idea behind population medicine is that it takes a broader view. Here, population is not only constrained to health, to human health, but also includes other population, other species, even other species, because the relationship that we are interacting with other species actually defines our health, actually affect our health. So population, this definition is kind of a broader picture than the narrowly defined population of human population. And it also infused with all other factors. What do we mean by all other factors? It's not only about health, but there are other dimensions that can determine health, that can affect health, like social factors, because our behavior, our smoking behavior, our eating behavior are also be influenced, be affected by our peers, by our culture, by our history, etc. So these social factors are all infused within this population medicine domain. And other factors like economic factors, psychological factors, also technological factors. If this area has a more advanced technology, and it may also affect our health. As I will give you some examples later in this class, you will see how technology can transform human health. So the second idea behind population medicine is that it takes a broader view because we are focusing on population rather than individual. And if we view this as a population level decision making, then there will be a lot of interactions between humans. And this kind of externality and this kind of interactions should be captured within population medicine. And this matrix actually shows the comparison between population medicine and other disciplines like clinical medicine, public health and preventive medicine, evidence-based medicine, and hot topic, precision or personalized medicine. And first is who to focus. Population medicine, as defined by its name, it focuses on population. It's always about the whole population, the average effect of this population, rather than the individual. And clinical medicine is focused on individual because if you see a doctor and the doctor will treat you specifically based on your own characteristics, he may ask you several questions about your syndrome and about your family history, etc., and then prescribe drugs based on your characteristics. And public health, it focuses on population. As we all know, we are doing a lot of research in public health. And then evidence-based medicine also focuses on population to get some evidence and to facilitate, to guide people to develop a practice guideline. And precision medicine is focused on individual. It's based on your own data set, on your own characteristics, and give you some suggestions, give you some recommendations specifically to you. It's optimized based on your own characteristics, your own genotype, your own behavior. So what are the differences between focusing on population and individual? Because sometimes it's good for you, it may not be good, may not be the best choice for the population. A typical, and also vice versa, a typical example is the vaccination. For example, if there is a vaccine and it's not 100% efficacious, a population level decision maker will think about, okay, shall I launch this vaccine or not? Because it's not 100% efficacious and its duration is limited. And should I launch it for free or should I set a specific price for this vaccine? And if I should set a price, how much should I charge for this vaccine to reach the optimal population level result? And all of these decisions involve a population level characteristic. Like if, for example, if you launch an HIV vaccine in China, which HIV prevalence rate is very low, rather than launch a vaccine in South Africa or Swaziland, where HIV prevalence rate is very high, then they may face different policy. They may make different decisions, even if the vaccine is the same. But for one individual, no matter he's like in China or in South Africa, it actually based on his or her own characteristics, whether he's at high risk and is he having some HIV positive partners or like these kind of characteristics specifically to this individual. Another thing for this vaccination, another difference is that vaccination has externality effect. What do we mean by externality effect? For example, if you are an individual to choose whether this vaccine is good for you, then if the decision is in the population level, you can see, oh, you don't need that vaccine actually, because, for example, if this population have 10 people and the other 9 people have already been vaccinated, and the vaccine is 100% efficacious, then this person, you will never get the disease, so you don't need that vaccine. So on the population level, it will be costing money if you are vaccinated. But for this individual, he may think, okay, I need to be vaccinated. I want to protect myself. I don't care about others. And because I also have like a lot of things that I want to think about. So individual level decision is different from population level decision, and population level decision are always attractive to those policymakers because they want to view the population as a whole. And so that is who to focus. And second is what to focus. First, whether they focus on prevention or treatment. As we said, population medicine actually combine prevention and treatment together. They may merge them together. They saw prevention as a sort of treatment. They saw treatment as a sort of prevention. They view health as a continuous state. So it focuses both on prevention and treatment. For clinical medicine, it focuses on treatment and how to prescribe, what drug should I prescribe to this patient. And for public health, we focus more on prevention, and evidence medicine focus more on treatment. And for precision medicine, we focus more on both. I think that is very interesting because previously I would think precision medicine, okay, it may be based on your genotype, and based on your genotype, then the doctors will prescribe drugs to you based on your own characteristics. And so I think it may focus more on treatment. But last time when Theo and I had a discussion, I think he brought up a very brilliant idea about precision medicine, because precision medicine can also be used as getting your own data, your own everyday data. For example, if you use Google, browse everything that you like, and Google and any other apps will capture your own preference, whether you like sugary drinks, whether you like salty food, and these kind of data can also be precisely defined by your own characteristics, and these behavior level data set can be used as a prevention to give you prevention interventions, to give you preventive suggestions. To say, okay, you need to have like healthy food or something like that based on your own preference. So precision medicine can also be focusing on prevention. But the key difference between precision medicine and population medicine is that precision medicine focuses on individual. It's always the best one for you, the best choice for you, not for the whole population. And what to focus? The factors considered, population medicine holds a broader view, a broader picture. So it's not only about human population, but also considering other populations, because the way that what we are interacting with other species, other populations are also affecting the population health, human health, and also considering social factors, economic factors, environment factors, whether there are air pollution, or water pollution, are the urban planning good for our health and our neighborhood safe or not, and other factors affect population. So it holds a bigger picture. In clinical medicine, focus on human and mostly not involving other social economic factors, and population health, public health are including a broader view, is focused on human population, social economic, environment, and other factors that affect human health. And evidence-based medicine focus on human. Precision medicine also focus on a lot of broader factors. And finally, the time span. I think most of the evidences, most of the literatures in clinical medicine and public health, evidence-based medicine and precision medicine focus more on current generation. I don't think very long. We focus on the current generation in short time span. And so we make choices based on the current status. But for population medicine, since population is not only affecting this generation, but also the population of the next generation. So it holds a bigger picture. As it holds a big picture, it focuses both on current and later generation. What we decide now, what we do right now may not only affect our own health, but also affect the later generations. Because behaviors can be infectious, and educational achievement of our parents may affect the next generation's health. So these are very interesting things to explore. And so besides those conceptual comparisons, now I think it would be interesting to give you some specific examples and also identify some important research topic in this field, because the goal of this course is first to get you to learn a set of methodologies to identify a causal relationship, then use these tools. These tools is not the end. The end is to use these tools to solve real-world problems. So we need to know what are the real-world problems there that needs our strength and needs our efforts to put into. So these are important research topics in population medicine and health policy. The first one is to identify highly effective preventive interventions. And to give you some example, this is an example in China. This study finds that community-based hypertension screening and encouraging people with raised blood pressure to seek care and adopt blood pressure lowering behavior changes reduced systolic blood pressure by 6 to 9 mmHg at the population level. So it's actually, and this is a long-term effect. It's actually 2 years after the initial screening, and systolic blood pressure was still reduced by 6 to 9 mmHg. So it's actually very effective for hypertension screening in older adults in China. And we can use the methodologies that we learn in this class to solve this kind of problems, address this kind of questions. But we also need to pay attention to what population that we are defining here, what population we are focusing on. And previously, we focused on the older adults in China and find a significant result, very cool, very big impact of hypertension screening. And now let's focus on South Africa. And we found that this study shows that community-based hypertension screening, yes, it also reduces systolic blood pressure for South African women and younger men, but not for older men. So when we do research, we also need to focus on like define what population we are focusing on. So maybe this intervention fits for one population, it may not fit the other population. And we should also be aware of the intervention package that we are defining here, even if they are both community-based hypertension screening, but due to cultural and differences, due to maybe differences in practical guidelines that those primary care health professionals are using, or maybe due to the difference in the quality of health healthcare systems, there will be differences in this package, this intervention package. So we also need to be aware of the intervention may not be the same in different settings. And another important research topic in population medicine and health policy is to identify social determinants of population health. And there are many social determinants of health. And the most common one that both healthcare professionals and economists are interested is education. So is education good for one's health and others' health? The evidence, a little evidence might say is there's no significant effect, but most of the evidence shows that education is good for one's health. And there are many literatures and that you can refer to. And it's not only good for one's health, it's not only good for own health, but also good for others' health. So there are spillover effect of this social factors that determine health. One study by Young Water and Gunther Fink, and they published last year, found that education, like the children's education, are good for their parent health. It actually increase the survival rate of their parents if their children are highly educated. So it's a very interesting thing to find, to also explore the spillover effect of these social determinants of health. And education is one example, and working is another example. As population aging, we're facing a lot of challenges. And one policy to address this challenge is to raise retirement age. But most of the arguments in the policy level the policy level arguments by policymakers, they focus more on economic perspectives and social consequences of raising retirement age. But actually, retirement age may also raising retirement age may also affect your health. So is retirement a bliss for your health, or is retirement good for your health, or is retirement detrimental to your health? This is a very interesting research question to explore, and there are a lot of literature on this, but most are recent evidence, and most are focusing on European countries and USA. There's a famous article by Bosch-Suppen, which was published in Journal of Economic Aging in 2013. Illustrated a lot of mix, a lot of puzzles currently in the economic aging world. And he brought up this raising retirement age. Actually, there are mixed evidence. We don't know. We are still unclear about whether retirement is good or not for your health, or bad for your health. And there are several other literatures. One published in 2017 saying the name of the papers is retirement blues. So they actually found that retirement is not good for your health. So these kind of evidence also can facilitate policy making at the population level. Also, it's not only about health policies, also about population policy and other kind of policies. We just need to bear in mind that health is an important dimension when designing those policies. And the third one is to develop optimal clinical and primary care practice guidelines. And as evidence-based medicine, focusing on developing clinical guidelines to guide the doctors, I think there also should be primary care practice guidelines, optimal design of those guidelines. And this is an example about this guideline for how to define your whether your hypertension, you're hypertensive or not. So how high is hypertension? Previously, we know that hypertension was defined as when your systolic blood pressure is higher than 140, and your diastolic blood pressure is higher than 90 mHg. But 2 years ago, the American Heart Associations updated their blood pressure definition based on the latest evidence. And their new definition of blood pressure is to define high blood pressure once your systolic blood pressure is above 130 and your diastolic blood pressure is above 80 mmHg. So these kind of evidence are important for designing the practical guidelines, both in the clinical field and in the primary care practices. And now currently, other countries are considering whether adopting this new guidelines or not. And so, as I said, we cannot see prevention treatment as separate, because disease is actually arbitrarily defined. Like previously, if your blood pressure is 135, you are not deemed as hypertensive. But now, if you update your based on the new evidence, now you are suddenly having a disease. So health is not a discrete state. You're healthy or you're not. You're having a disease. It's actually our continuous state. And this is a good example to illustrate that idea. And another important research area is health system reform. How to design a health system. Health system includes the healthcare service provision. And I would like to say there are 3 basic components in the healthcare service provision. First is health workforce, the doctors, the education system of the doctors, the payment scheme of the doctors, and the career design of the doctors. They are affecting the healthcare provision, healthcare service provision. And then there's healthcare institution, the public hospital and the private hospital, the private clinics, the public health services institutions, etc., and how they manage their own institution, and what are the payment scheme, what are for their for the hospital, and are they more flexible to hire doctors, or it's not their own decision to hire doctors? So there are many things that are within the management of the healthcare institutions that affect healthcare service delivery and provision. And then it's healthcare service system. So how you design the system? What are the mechanisms that you pay the price, and what are the mechanisms that the funding and keep everything working with the financing system in the healthcare service system design? So those 3 basic elements are for healthcare service provision. And then it's the insurance design. For the insurance design, most of us in our department focus on health insurance, and universal health coverage. It increase your health insurance coverage. But there are also other elements, other components within health insurance design. For example, financing, how you should finance through tax or through social insurance, or through other out-of-pocket payments. So those are financing scheme. And payment, how you design a payment scheme. Do you use a fee for service, or do you use global budget to pay the doctors, or do you use diagnose analysis group, DRG, and Germany is using DRG to pay inpatient services. So those are all contributing to the incentive that healthcare providers facing. So it will affect the efficiency of the health system. And now we have long-term care insurance is an emerging insurance that was introduced in Germany in 1994, and Japan adopted long-term care insurance in 2000. And South Korea adopted long-term care insurance in 2008 because population aging is a big challenge, and one of the challenges is we are facing many more and more older adults who are disabled, physically disabled or mentally disabled. So they need to be taken care of, and long-term care insurance is a way to provide to cover their needs and shoulder the burden, the care burden by the society. And finally, in the health system is the medicine, the pharmaceutical, how you prescribe drugs, how do you design, what's the drug pricing schemes, and those medicine policies are also affecting the health system performance, like the cost effectiveness of the medicine and the prescription behavior of the medicine, and how you acquire those medicine from each hospitals, etc. So these are all elements in the health system reform. And this is an example of health system reform on the impact of health insurance on health and other outcomes for different subpopulation groups. So what's the impact of health insurance on health and other outcomes for different subpopulation groups in one country, for the whole population in one country, for different countries in the short run and in the long run? So the impact of health insurance is a big topic, attracting the attention of the researchers from different disciplines. And we may think, okay, increasing health insurance coverage definitely contributes. It's good for your health, and it will also reduce your health expenditure, but it's not necessarily leading to those outcomes. Why is your healthcare expenditure may not be lowered after you have health insurance? Why is that? Because when you have health insurance, then you may have more healthcare utilization, so you may visit hospital more. And if your health insurance also have copayment, then every time you go to the hospital, even though you are covered by health insurance, you still need to pay a small amount out-of-pocket money. And since your healthcare utilization is increasing after you have the health insurance, then your total out-of-pocket health expenditure may not be decreasing. So health insurance may not necessarily reduce your out-of-pocket money, and it also may not improve your health outcome. And this evidence exists in especially in low and middle income countries. And this book, published in 2011, it summarizes the impact of health insurance in low and middle income countries systematically. And after that, there are many other different, latest new evidence on the impact of health insurance on health. In low and middle income countries, we know that the quality of healthcare are not very good. So if one has a health insurance, is covered by health insurance, then it's because of the quality of healthcare services not good, that it may not significantly improve this person's health. So there are mixed evidence answering this question. And there is a famous book in health system reform that if you are interested, it's called Getting Health Reform Right. And it gives the basic concept, basic elements of the health system. And it was written by Michael Roberts, William Xiao, Peter Berman, Michael Resch from Harvard School of Public Health. And they published this book in 2003 to guide health system reform in different countries. and the book was translated in different languages, and it was translated in Chinese and published in 2010. And this book can give you the basic understanding of what we are evaluating a health system reform, what goal we want to reach. And in this book, they set 3 ultimate goals. One is to improve population health. Always, as always, when policymakers initiate a health system reform, the ultimate goal is to improve population health. Like all the other goals are not ultimate goals, are intermediate goals. And we are not only caring about the average population health of this population, but also the distribution of population health to show equity. And the second ultimate goal is the financial protection. So also the average financial protection and the distribution of the financial protection and patient satisfaction. So these 3 goals are ultimate goals that they set in this book. But it is really hard to directly evaluate ultimate goals when we do a causal evaluation on different health system reform policies. So most of the studies focus on intermediate goals, which are also written in their book. There are 3 intermediate goals. One is access. Access has physical access and effective access. Physical access, for example, if you want to see a doctor, then your doctor is next to your home. So it's really quick because you don't need to travel a lot. And this kind of access of physical access. And effective access is that when you have a disease, then you can receive the treatment in time. You have the money to get you have the money, then you don't postpone your disease treatment. So you can just go to the hospital and receive the care from the doctor. So the effective access is that you can get your treatment in time. And quality is the second goal of health system reform. Quality has clinical quality and service quality. Clinical quality, are you receiving the right treatment for your disease, the optimal treatment for a disease? And service qualities, are you receiving the optimal, the best service? Are the doctors giving you good attitude, good treatment, and care about you? Are the environment, the hospital environment good? Are you satisfied? So these are all service quality. And the third goal, intermediate goal, is efficiency. Efficiency, there are 2 kinds of efficiencies. One is technical efficiency, one is allocative efficiency. By technical efficiency, we mean that are the healthcare providers giving you the right healthcare services in a minimum cost. So that's a technical efficiency. So the healthcare services is provided to you with minimum cost. And for allocative efficiency, it defines the combination of those healthcare services are optimal. So it's allocative efficiency. Are we providing the optimal combination of healthcare services? So access, quality, and efficiency are the intermediate goals for healthcare system evaluation. And the 5 important research topics is health in all policies. And this is very interesting because as we know, health can be determined by social and economic factors, and so it can be determined by population policies such as retirement policies, whether you set retirement age as 60 or you set retirement age as 70, all affect health. And whether it's mandatory retirement age policy or voluntary retirement age policy, it can also affect health. And education policies can affect health. Technology policies can affect health. Social and economic policies can also affect health, and so on. So these are research topics that we should bear in mind, and it's actually rarely examined for some of them. And so there are still vast gap in the literature in this domain. And we are living in a world that is transformed by advanced technologies, such as artificial intelligence, digital health, mobile health, etc. And this is an example about self-driving cars. In the future, currently in some countries, they're actually piloting some self-driving cars, as in the California in the United States. But in the future, maybe 20 years, maybe 30 years, it might be prevalent for us to use to start to drive self-driving cars. But self-driving cars can also affect human lives. And one article published last year by The Economist magazine, it says, a different world, self-driving cars will profoundly change the way people live. And in the article, they cite a figure estimated by the BCG Boston Consulting Group. They said 90 to 94% of road traffic injuries are due to human errors. Wow, that's like a really big number. So if self-driving cars can replace human driving cars, are we reducing the road traffic injuries by a big amount? So that is a very interesting question to ask. But since we don't have enough evidence to give us a concrete answer, but we can imagine it will profoundly affect our lives. Not only traffic injuries, but also health. Now, since some people don't know how to drive a car or due to other reasons, but if they have self-driving cars, it may, or maybe not, they may use self-driving cars more often, and because it's convenient, and it may increase the sedentary frequency for this person. So he may be more sedentary or affect his other behaviors. So it may also affect health through behavior change. And also social and economic outcome can be affected by technology, such as self-driving cars. And this is just one example in the domain of, under the topic of health in all policies. But it is very interesting to infuse health dimension into these policies and look and explore what are the causal relationship of different policies in other sectors affect healthcare and health. And the final research topic that I gave you as an example is the health, society, and wealth. Disease burden, we know DALI, disability adjusted life years can measure disease burden from the global burden of disease study in IHME. They measure disease burden in health terms. And we know that disease burden can also be measured in economic terms because, for example, the cost of illness approach, they just aggregate direct cost and indirect cost together. Like if people are ill, they go to see a doctor and it will generate treatment cost. And so the family on the macro level, for the families, for the households, they will lose money by getting a disease. So disease burden can be measured in economic terms. And also from macroeconomic level, disease burden can also measured in macroeconomic terms, because if in this country, the population are less healthy than another country where the population is very healthy, this country may lose money, may may lose money because their population are not healthy. because if people get ill, the labor supply will be reduced, the quantity of labor supply will be reduced, the productivity level will be reduced, will be lower, so the effective labor supply will also be reduced. By effective labor supply, we can see it as human capital accumulation weighted by education and experience. So if this population is unhealthy, then it will pose a burden, a macroeconomic burden on the country's GDP. And it also, because it will also trigger treatment costs. And some of the treatment costs can be otherwise diverted to physical capital accumulation, but now it can't, so it can also lower the GDP from the physical capital accumulation channel. So disease burden can pose health, can be measured in both health and economic terms. And also we should know that interventions, health policies, not only generate health outcomes, not only improve health outcomes, but also would improve broader social and economic benefits. For example, vaccination. It can not only protect us from getting the disease that is a benefit in health terms, it may also generate long-term social and economic benefits, because if children are vaccinated, they may be less frequently to get the disease, and the absenteeism rate may be lower, and they will pay more attention on the content when they attend the school. So they may achieve a higher education level, and in the long run may make more money. So these are broader social and economic benefits of health interventions. And and this is an interesting comparison: cost-effective analysis versus cost-benefit analysis. So cost-effective, what are the differences? Cost-effective analysis actually measured, so if I invest $1, then how much health gains can we get? For example, the death averted by investing 1 unit of money into this intervention. So the cost-effective analysis actually gives us the benefit in health terms. And cost-benefit analysis actually gives us the benefit in monetary value, because we know reducing disease or improving health can actually have economic consequences. So they use that idea to analyze, to explore what's the benefit, what's the monetary value to initiate this health intervention or health program, health improving program. So that's the cost-benefit analysis. They measure the gain in monetary value for less labor loss and less treatment cost. So this is a famous example in this domain. This is a deworming program in Kenya, and it's a random control trial. And in the trial, the researcher randomly select those children and prescribe them with deworming drugs, because they suffer a lot from worms, and they find that just by giving them the drugs, the deworming drugs, it can largely improve their education outcomes. And the researchers followed these children for a decade, more than a decade, and found that it can also boost their future income. So it was written by Professor Mingo and Professor Michael Kramer, and they published these two famous articles in the economic literature. So this example actually shows how health interventions pose a significant benefit on society and economic outcome, and eliminate poverty. And this guy is actually the author in this for these two articles, deworming in Kenya And his name is Michael Kramer. He has just won the 2019 Nobel Prize in Economics. And because of his contribution in developing a new approach to alleviating global poverty. And it's very important and to know that health is the interaction of health, society, and wealth. They have close link. Another example is to view this on the macroeconomic level, because previously he followed up those individuals for years and measured their economic gains, their income gains. So that's from a micro level. But we know that on the macro level, what are the macroeconomic impact of those interventions? And this study, this is our recent study, we've focused in China and found that if China implemented wide-ranging tobacco control policies, the Chinese economy could save $1 trillion for the next 15 years, equivalent to adding a 0.4% dividend annually. So on a macro level, health policies, health interventions can also generate a big amount of money and boost the economic growth. Okay, so that ends our examples, illustrations in the important research domains in population medicine and health policy. And in the next part, I'm going to introduce you about the brief concept of evaluations. I hope these examples and illustrations can deepen your understanding in causal evaluations. So these are some questions to identify causal relationship. Does expenditure on health programs causally increase health outcomes? How big are the causal effects of family planning on fertility? And how large are the long-term wealth effects of human capital investment, etc., etc. Actually, the examples that I gave you in the previous slide are actually all causal evaluation questions. So you may understand it a little bit now. And this is an example. So Jack went out in the rain and got a cold. Had he not gone out in the rain, he would not have gotten a cold. So did going out in the rain cause Jack's cold? So it is a stupid question, but I hope it can deepen our understanding of defining a causal effect. So this is definitely a causal effect, right? No one will disagree, right? So this is a causal effect. And this is another example. So Steve took a pill and his headache was gone. Had he not taken the pill, his headache would go away anyway. So did the pill cure Steve's headache? No. So this is not a causal effect.
But what about placebo effect?
Placebo effect?
Yeah.
Yeah, that's a good idea.
I mean, it could still cure someone's disease, although it's not the.
But if he doesn't, had he not taken the pill, there were no placebo effects also, and his headache would go away anyway. So it's not his headache has gone. It's not caused by the pill. So I hope those two examples can give you some ideas about what is a causal relationship. This is the data that we are dealing with every day. We get our hands dirty with the data. But the difference is that this is ideal data. In the ideal data, we can get all the information about each individual. And now we want to explore are there any causal effects of obesity and on blood pressure. So for the first person, his obese. He's exposed to obese. And we can measure, in the ideal data, we can measure the blood pressure. If he is obese, it's 124. And then we can also measure his blood pressure in the counterfactual scenario if he is not obese. So we know that if he is obese, then the blood pressure is 124. If he is not obese, then the blood pressure is 120. So the effect of obesity on blood pressure for this individual will be 4 mmHg. And for the second individual, we can also calculate it the same way by subtracting from 135, which is the blood pressure for this patient if he's obese, minus 135, the blood pressure if he's not obese. So the causal effect of obesity on blood pressure for this second individual is actually 0. So these are individual level causal effects of obesity on blood pressure in the ideal data. But in the real world, it's not that easy. If we can get all the counterfactual scenarios, it will be easy for us to identify causal relationship. But in the real world, the data set that we get look like this. So for the first person, we know, okay, he's obese and his blood pressure level is 124. But we cannot observe the counterfactual scenario where he is not obese. So this situation exists for all the other individuals in the data set. So it makes the question very difficult for us to solve. Because now we cannot, we lose the counterfactual data set. Then we cannot simply get the answer of the causal effect of obesity on blood pressure for these individuals. So that's why we need a lot of methodologies to identify a causal evaluation in the real world because of this complexity. And so this is a concept about average treatment effect, because we know that so I will also use the ideal data as an example, because it may help you understand. So the average treatment effect is actually the average of the whole population, because we are dealing with data on a population level. We are making policies, making suggestions, evidence-based suggestions on the population level, because we are focusing on population medicine, not precision medicine. So we want to calculate, at the end, we want to calculate the average effect, average causal effect, average treatment effect. So we don't care about what's the causal effect for each individual. We just care about the average. And average treatment effects for this population, this 5 patients, is actually, to summarize all the individual level effect, causal effect, and divided by 5. So that equals, that gives us the average treatment effect. 4 plus 0 plus 10 plus 22, which is 36, plus 2, 38. And divided by 5, which is 7.8. So this gives us average treatment effect. And there are also 2 other concepts: average treatment effect for the treated and average treatment effect for the controlled. And what is the concept of average treatment effect for the treated? So I've also used this ideal data set and for this population, because for the people who are exposed to this factor, their characteristics may be different from those people in the control group. So that's why we want to introduce these 2 other concepts. So now, who are in the treatment group? The first person, he's obese. The second person, he's obese. So, and the 5th person, he's obese. So we know that in this population, the first, second, and fifth person are, we call them, they're treated. So the average treatment effect for them is actually 4 plus 0 plus 2 divided by 3. So these are the which gives us 2. So the average treatment effect for the treated equals 2. And this is the average treatment effect for the controlled. So we just calculate the average treatment effect for those people who are not obese, which is the third person and the fourth person. And so the average treatment effect for the control equals to 10 plus 22 divided by 2. So it's 16. So, okay, so just now we go over some concepts and hope it can give you some understanding of the causal relationship. And now we'll introduce you to some assumptions to estimate a causal effect. In a randomized experiment, the most important assumption is exchangeability. So it's actually, so by definition, is that the potential outcome had treated been untreated is the same as the outcome among the untreated and vice versa. So it looks like not very intuitive, but intuitively, it says the groups, the two groups, the treatment group and the control group, the people, they are identical. So that's exchangeability. They are exchangeable. So that's it. Don't worry if you don't understand the concept that in the next several slides, because the next for the next lecture we will introduce you more detail into potential outcome model. So now we just intuitively understand the causal relationship, the causal evaluation. That'll be fine. So the assumption of exchangeability actually says the population in the control group is identical to the population in the treatment group. And in a randomized control trial, if we're fully randomized, if successful, guarantees exchangeability at baseline for treatment assignment. So it's actually guarantees baseline at guarantees exchangeability at baseline. Important at baseline and for the treatment assignment. But there are sometimes things may make it complicated. And for example, if there is differential loss to follow up, exchangeability may not hold later in the follow-up, and we may need additional assumptions regarding determinants of loss to follow-up. So, for example, if we need to figure out what are the determinants of loss to follow-up. If the determinants of loss to follow-up actually affect the potential outcome, then we may be aware of that. And so we may need additional assumptions in this. So it's not exchangeable in these two groups. And if there is imperfect adherence with the treatment, and we should also be careful that the effect of assignment to treatment might be different from the effect of taking the treatment. But we are not dealing with randomized control trial in this class. We are actually focusing more on observational study. And because randomized experiment is very expensive and sometimes not very ethical, and there are also political concerns, it's hard to do, especially for doctoral students. So we use available data sets in an observational study, and we can still identify some causal relationship there. And assumptions to estimate a causal effect in an observational study, we know that exchangeability often does not hold. I think it always does not hold because of confounding. And this concept we'll also introduce in the later lectures. And so we need conditional exchangeability. So we condition on these confounding factors. Then we say they are exchangeable. And there are also other assumptions. We assume all the confounding factors that are observable. So we have included all the observable confounding factors. And there are no confounding factors out there that are unobservable. And then if we conditional on those factors, then we say, okay, these groups are now exchangeable. So conditional on a set of covariates, the potential outcome under treatment is the same among the exposed and unexposed. For example, given the same quality and quantity of diet, the blood pressure levels in the obese, had they not been obese, would be the same as the blood pressure levels observed in the non-obese. And we can think of this as randomization within levels of confounders. Oh, this slide, I borrowed it from Theo. I get his permission. I think this is a great slide. And Theo published in an article in the Journal of Clinical Epi in 2017. I think it's very clear. It illustrates what are the differences for different approaches. And first, the experiments, the randomized control trial. We know if it's fully randomized, the two groups are exchangeable. So we don't need to make other assumptions to say, okay, this is causal evaluation, this is causal relationship. We don't need to make additional assumptions. And unobserved confounding control of selection, unobservables are all, we can control all the confounding factors. We can control all the confounding factors. So that is ideal experiment. But our focus is not on RCTs. Our focus is actually on the quasi-experiments. And the instrumental variable approaches, we find an instrument, and then we say, okay, all the effects of the exposure to the outcome can only be can through that instrument, and then we can have a technique using instrumental variable approach to get a causal estimate. And for the regression discontinuity design, it also borrows the same idea. Okay, we have a threshold, arbitrary threshold that define that separates the control trial and the treatment trial, the control group and the treatment group. So so if that is the case, if there is a arbitrarily chosen threshold or cutoff that define treatment group and control group, we can think about using the regression discontinuity design method. And for the instrumental variable approach and the regression discontinuity design approach, they're very powerful tools to identify a causal relationship in the observational study. And they need less assumptions, although they also need some assumptions, but it's less assumptions. And there are two other quasi-experiments, difference in difference approaches and fixed effect approaches. And especially the difference in difference approaches, they are commonly used in the health system reform literature. We first have a treatment group and a control group. Before the reform, we measure them. We measure the outcome at the baseline, and then we assume they follow parallel trend. And then after the reform, we measure them again. We measure the outcome for the treatment group, and then measure the outcome for the control group. And then we get the causal estimate. And for the difference in difference approach and fixed effects approach, they are actually weaker for identifying a causal relationship comparing to instrumental variable and regression discontinuity design, because in order to say the effects are causal, we need to make more assumptions. For example, we need to make assumptions that the parallel trend assumption in the difference in difference approach, and we can only control for time invariant factors in the fixed effect approaches. But no worries if you don't understand the terms here, because we are going to introduce you about these methods in the later lectures. And the non-experiments, the regression, matching, and stratification, they cannot capture the estimates from these methodologies are not causal, because we need very strong assumptions. But actually, we cannot observe all the confounders out there. And so even if we control for the observed confounders, we cannot say they are all the confounders. And our class, okay, so our class, we actually will focus on causal experiments. Major focus on causal experiments. And in the next lecture, Nikki will will go through the basic concepts and more detail of the potential outcome model. And then I'll introduce you the DAG, the directed cyclic graphs. And hopefully we can cover all these materials in this series of lectures about regression discontinuity design and how to implement it, instrumental variable approach, fixed effects approach, and difference in difference. But we I also need to discuss with Gio, and he also have other ideas. So maybe in the next few days, we will give you a syllabus of this, send you your syllabus of this class, and with more materials and textbook of this course. And I hope you guys enjoy it. It seems that any questions? It seems that we are finishing early, right? So.
Oh, are you going to send